Hello, everyone, and welcome to the webinar entitled Syringe Services Programs, a Critical Public Health Intervention, a webinar hosted by the Office of the Assistant Secretary for Health. My name is Julie Cahoon, and I am from Kaufman & Associates, assisting with today's webinar. Before the presentation begins, I would like to highlight the main features of your webinar interface. You should all see the first slide of the PowerPoint presentation in the middle of the screen, and to the bottom right of your screen is the Q&A pod. Please enter a question for our presenters at any time into the Q&A pod. Questions will be addressed at the end of the presentation. If you need technical assistance during the webinar, please type the issue into the Q&A pod, and one of our tech support staff will respond to you directly. Finally, please be aware that all phone lines have been muted and this presentation is being recorded. I will now turn it over to Sharon Ricks with the Office of the Assistant Secretary for Health. Sharon?
Thank you so much, Jennifer, and good afternoon, everyone. Welcome to our webinar. We are excited that more than 1,700 of you have taken the time to join us today. We have representation from state and local public health, law enforcement, harm reduction organizations, the faith community, substance use disorder programs, federally qualified health centers, other providers, and elected officials, and we appreciate your interest. My name is Sharon Ricks, and I am one of 10 regional health administrators across the nation who represent the Office of the Assistant Secretary for Health at the U.S. Department of Health and Human Services. Regional health administrators utilize their regional expertise and networks to catalyze public health action on emerging public health issues. Today, the Office of the Assistant Secretary for Health is presenting Syringe Services Programs, a critical public health intervention, in partnership with our colleagues at the Centers for Disease Control and Prevention, the Health Resources and Services Administration, and the Substance Abuse and Mental Health Services Administration. This webinar signals the launch of an effort being led by the Office of the Assistant Secretary for Health in collaboration with federal, state, and county stakeholders to create and expand syringe services programs in vulnerable communities across this nation. Our agenda is on the screen, and our speakers include Admiral Brett Giroir, Assistant Secretary for Health and Senior Advisor for Opioid Policy at HHS, Rear Admiral Jonathan Merman, Director at CDC's National Center for HIV/AIDS, Viral Hepatitis, Ms. Heather Houck, Deputy Associate Administrator, HIV/AIDS Bureau at the Health Resources and Services Administration, and Dr. Jim Gandotra, Chief Medical Officer at the Substance Abuse and Mental Health Services Administration. Before we get started, I'll cover a few logistics. Your lines are currently muted. If you have any questions during the presentation or during the Q&A, please type them into the Q&A pod in your control panel. And during the Q&A session, we will respond to as many of those questions as possible. Also, at the close of the webinar, there will be a pop-up screen with 6 questions for you to complete. This is your opportunity to share your thoughts about this and future webinars. Also, please look for an email from us sharing a link to the slides, a recording of the webinar, and the contact information for your OASH Regional Health Administrator. So without further ado, I am pleased to introduce our first speaker, Admiral Brett Giroir, Assistant Secretary for Health and Senior Advisor for Opioid Policy. Admiral Giroir.
Good afternoon, and to maybe some of you, good morning, wherever you're joining us from. Thank you, Sharon, for the introduction, and I want to thank everyone for joining us here today, and particularly for all our colleagues, really the leaders within their agency, to talk about syringe services programs. If I could have my first slide. Previously, I would have said as a subtitle, Syringe Services Program, an evidence-based public health intervention. And clearly, syringe services programs are an evidence-based public health intervention, but I think they've transcended evidence-based to becoming a critical public health intervention that we want to stress. My goal over the next 8 minutes is to provide a few comments on the nature of the overdose crisis that we're experiencing, the intersection with the syndemic of infectious diseases, and then some introductory remarks about syringe services programs, just as an introduction for the subject matter experts that will follow. As we all know, and these are 2017 data, which are the last complete validated year, the overdose crisis is the most critical public health challenge of our time. It complicates and makes worse almost every other public health issue that we have. In 2017, there were over 70,000 drug overdoses, of which over 47,000 were opioids. The predominant opioid overdoses have transcended from prescription to the second wave of heroin to the third wave of fentanyl. However, even now, as we're gaining support and improving on some of our opioid prescribing and use, we are in the middle of what many are calling, and we certainly are calling, the fourth wave of the crisis. That is the increase in cocaine and psychostimulants, predominantly methamphetamine, that is being not only smoked, but also snorted and injected, which raises the opportunity for infectious disease transmission on top of and further than the opioid crisis. On the next slide, it just illustrates the degree to which methamphetamine is a growing threat that we are addressing head-on within HHS and the intergovernment. These data are from the July 2019 release from the National Center for Vital Statistics. And of the 34 states that report monthly deaths by type of drug, we now have 12 states for which methamphetamine mortality is higher than synthetic opioid mortality, or methamphetamine even more than fentanyl, and 2 states, Oklahoma and Hawaii, for which methamphetamine deaths surpass all opioid deaths together. So before we get specifically into syringe services programs, I want us all to be cognizant of the evolutionary nature of our overdose crisis. Clearly, we're in the fourth wave. Although opioids are reducing to some degree, we're now seeing methamphetamine on the rise, so we can only anticipate more and more issues. Next slide. So as we all know, and is the basis for this seminar, there are profound infectious consequences of the opioid epidemic, and I think everyone on the line are probably familiar with the transmission of HIV. I will make a couple of other comments about this, about hepatitis A and B, and certainly hepatitis C, which is growing at enormous and alarming rates. All of these diseases can have lifelong implications, including chronic hepatic failure and the need for transplant or the development of cancer. We also see a variety of bacterial and occasionally other organism infections, such as endocarditis, and significant skin, bone, and joint infections that by their nature are very difficult to treat and often are caused by microbial resistant organisms that may take weeks or months plus surgical intervention in order to cure. We've been very active in this since very early on. I joined in February of 2018. We almost immediately thereafter had a National Academies of Science, Engineering, and Medicine workshop to understand and to help lay the groundwork for why we can't work against these issues separately, that they truly are part of a syndemic. They are two epidemics, but they are intersected and interconnected and mutually reinforcing. Next slide. I think many of you know the President announced the Ending HIV initiative within America during the State of the Union address, and all our agencies, certainly the ones represented on this call, SAMHSA, CDC, and HRSA, have been actively involved in beginning this program and developing the platform for which we will reduce infections of HIV by 90% within 10 years. And as you can see right now, of the nearly 40,000 new infections, about 9% are associated with drug use, about 6% primarily with people who inject drugs, and another 3% with gay and bisexual men who inject drugs. What this doesn't tell, however, are significant local outbreaks, local epidemics that occur primarily with HIV and hepatitis C that are associated with drug use, and you'll hear more and more of this later on in the program. So as many of you know, we have an overall 5-point high-level strategy at HHS to improve our response to opioids, but also to all drugs in general. First is better addiction prevention, treatment, and recovery services. Second is better data so that we know exactly where the problems are, who to target our responses to, and to make sure that our interventions are helpful. Better pain management. This relates primarily to opioids, but opioids are also a primary factor in other substance use, such as methamphetamine as a co-substance use. Better targeting of overdose reversing drugs. We all know the naloxone story, and you'll hear a lot more of that in the upcoming weeks. And of course, better research across the board. How can we improve prevention? How can we improve community interventions? How can we improve MAT? And how do we integrate recovery services to get the best possible outcome? I do want to say that we are very heartened that there has been a very significant improvement in evidence-based treatment. Much of this led by the work of SAMHSA and Dr. Ellie McCann's Katz and all the technical assistants throughout the country, as well as CDC, CMS, FDA, and certainly our office. And evidence-based treatment is effective. The cornerstone of that is FDA-approved medication. And our latest data show that at least 1.2 million Americans are now getting MAT, which is historic in its number and also in its rate of rise. The result of all our interventions, again, is promising. This slide depicts the data that was released 2 weeks ago from the National Vital Statistics System that showed that, believe me, we are still in the midst of this crisis with far too many Americans dying, but for the first time since 1990, we saw a decrease in year-to-year mortality from overdoses. In this case, a 5.1% decrease in deaths in 2018 compared to 2017. While this did make the news and was newsworthy, this graph really shows the rolling 12-month overdose mortality starting in 2015 and ending in our last reporting period. And you can see that we did peak many months ago, and actually this is the 7th consecutive month in a row for which overdose mortality is lower compared to the year prior. So let's get to the reason we're here. Syringe services programs have long been supported by HHS as really an essential part of this endemic solution. And I do say an essential part of this endemic solution, and you will hear more from the subject matter experts, because there's clear evidence to show that syringe services programs prevent the transmission of infectious diseases like the hepatitis virus series and HIV, and is also very important to prevent bone and skin and endocarditis infections. I think we all know that. But what I like to highlight in this is that SSP participation, and again, there's much data out here, not only helps solve the infectious disease syndemic, but data show that participants are 5 times more likely to enter drug treatment and 3.5 times more likely to cease injecting compared to those who don't use SSP programs. So not only do we improve the infectious disease outcomes, but we also use this as an on-ramp into treatment and recovery. So it clearly intervenes and effectively engages in both sides of this endemic question. On the next slide, you see that appropriations language from Congress for fiscal years 2016 and 2019 permits the use of funds from HHS under certain circumstances to support SSPs, with the sole exception that funds may not be used to purchase needles or syringes. And there is guidance that is located there by the web address and will also be gotten into later on in this program. So this is a general slide to just say that we are divided in regions. And we talked about putting states where syringe services programs may be illegal, where they may be legal, where there's no law. But this is a rapidly changing environment. In some states where syringe services may be legal, may still have a tremendous need for more syringe services or mobile syringe services that go around the state and reach the hard-to-reach population. So what we really encourage you to do, and you'll hear more about this, is to please contact the regional health administrator in your regional area. All the regional health administrators have been working on syringe services programs as one of our comprehensive strategies for at least the past 6 months and are quite expert in the area and know the background of the states, whether there's a legality issue or whether there's just need for an expansion, whether there's need for education, outreach, and engagement. So please reach out to your regional health administrator because there's a lot of room for improvement in both making them in areas where they do not have them and in expanding them in the areas that do. So on my last slide, I just want to thank everyone for being on the call. I want to thank all the participants for providing your attention and your input. And please feel free to follow me on my Twitter account. And also feel free to provide email feedback to my email address because we really want to be able to amplify all the good things that are going on and understand the needs from throughout the nation. Thank you very much, and I look forward to listening to the rest of the seminar.
Thank you so much, Admiral Giroir. That was a great overview of the waves of the epidemic and the infectious consequences, and also the role of SSPs as part of this endemic solution. So our next presenter will be Rear Admiral Jonathan Merman. He's the director of CDC's National Center for HIV/AIDS and Viral Hepatitis, and he'll share more about CDC's perspective and resources related to this topic. Rear Admiral Merman.
Good, thank you. And then thank you, Admiral Giroir, for a powerful presentation and your ongoing leadership in this public health crisis. As you described, America is facing a crisis at the intersection of opioids and infectious diseases. And today, what I'd like to talk about is how, although challenging, it is possible to win the fight and save lives and money at the same time. Next slide. So Admiral Giroir spoke about the increases in injection drug use that led to a massive increase in overdose deaths. In addition to this tragic consequence, injection drug use has also led to increases in hepatitis C and hepatitis B infections, which can be transmitted through unsterile injection equipment. CDC estimates more than 40,000 people are newly infected with hepatitis C virus annually, and about 20,000 with hepatitis B virus. Hepatitis C virus infections have increased over 250% since 2010, as seen on the chart to the left, the vast majority due to injection drug use. Together, viral hepatitis causes over 22,000 deaths a year in the United States, a number preventable with early screening, curative therapy, and sound prevention. Similarly, one of the greatest successes in HIV prevention has been among injection drug users, with an 80% decrease in injection drug use-associated infections over time. But since 2011, our progress has stalled, and we are at risk of reversing our success, as seen both in the figure shown here and in multiple outbreaks of injection drug use-associated HIV that I'll talk about in a moment. Next slide, please. So what parts of the country are at risk? First, the map on the top right of the slide shows the amount of opioids prescribed by clinicians in a state, which varies considerably. On the left is a map of the nation with drug overdose deaths by county, with the highest highlighted in red and orange. And there are major problems occurring in Appalachia, the West, and the Northeast. And every state has seen an increase in overdose death rates since 2010, often profound increases. On the bottom right is a map of hepatitis C infections by county, also concentrated in Appalachia, the West and Northeast. So why are these maps so closely aligned? Because these are intersecting epidemics, and today the vast majority of people who are getting infected with hepatitis C virus are doing so because of sharing needles and syringes during injection drug use. In addition, since mid-2016, we've been experiencing a nationwide multi-state outbreak of hepatitis A infections, primarily among people who use drugs or who are experiencing homelessness. In this outbreak, the geographic distribution is similar to the other maps because hepatitis A virus is spread through fecal-oral contact and sharing contaminated drug paraphernalia. Foodborne infections in these outbreaks are rare. So far, there have been more than 22,000 cases, over 13,000 hospitalizations, and over 200 deaths. These outbreaks are causing more hospitalizations and deaths than usual, primarily due to the fact that patients are older, some have already damaged livers from alcohol or co-infections with hepatitis B or C, and some persons are homeless. Vaccination of these vulnerable populations is vital, but it's difficult. Responses by many states and counties have shown that stopping the outbreak will require we do not assume people at risk will come to us and seek out vaccines in the healthcare system. Rather, we need to bring hepatitis A vaccine to them, whether it's substance use treatment programs, jails and prisons, emergency departments, or syringe service programs. And our outbreaks are not just involving hepatitis A. In 2015, Scott County, Indiana saw an outbreak in which 235 people who inject drugs were diagnosed with HIV, 90% of whom were co-infected with hepatitis C. In the town of Austin, indicated by the gray shading on the map at the top, about 5% of the adult population has HIV infection, which is the highest prevalence in the nation. There will be more than $100 million in lifetime medical care costs related to this single outbreak, the brunt of which will be paid for by the state and federal government. On the bottom of the slide, another example is in Cobb County, West Virginia, where they typically have had fewer than 5 HIV cases among people who inject drugs annually. But this year and last, they've documented a total of 58 new cases. Next slide, please. In addition to HIV and viral hepatitis, as seen in these figures, we have seen rising STDs in the country and an increasing proportion of heterosexual men and women with syphilis report using drugs, primarily methamphetamines or heroin, or report having sex with someone who injects drugs. Next slide. Finally, as Admiral Giroir had touched on earlier, bacterial and fungal infections associated with injection drug use are also on the rise. And there have been increases in hospitalizations for endocarditis, septic arthritis, epidural abscesses, and osteomyelitis, as well as invasive staph infections among persons who inject drugs. So what can we do? What can we do to change this course? First, we can prevent harmful opioid use by reducing opioid prescriptions and implementing effective drug use prevention programs in schools and communities. Next, we can screen for and treat infectious diseases like viral hepatitis, HIV, and other infections so people who inject drugs can live healthy lives. We can ensure people who need it get access to medication-assisted substance use treatments. They can stop using drugs and provide naloxone to prevent overdose deaths. And lastly, we can prevent infectious diseases through syringe service programs and vaccination, and by treating people who have hepatitis C, hepatitis B, and HIV to reduce or eliminate infectiousness. And we will want to do this nationwide. In this map in pink, we can see counties CDC identified several years ago as being at risk for an outbreak of viral hepatitis or HIV. And in green, states that have examined local epidemiologic data and been provided a determination of need. As Admiral Giroir noted, federal law permits the use of funds from HHS to support syringe service programs. A prerequisite for using HHS funds for this purpose is for eligible state, local, tribal, or territorial health departments to consult with CDC and provide evidence that their jurisdiction is experiencing or at risk for significant increases in hepatitis infections or an HIV outbreak due to injection drug use. This is done by applying to us for a determination of need. And at this point, every state that has examined their data has seen a problem. So with the potential for additional resources facilitated by the determination of need, jurisdictions can scale up SSPs. But what really are they? Well, comprehensive syringe service programs are proven effective community-based programs that, in addition to access to and disposal of sterile syringes and injection equipment, ideally provide a range of helpful services such as vaccination, testing, and linkage to care for infectious diseases, naloxone to prevent overdose, and linkage to medication-assisted therapy for substance use treatment. Next slide. They are safe, effective, and reduce overall health costs. And nearly 30 years of research has shown that syringe service programs prevent transmission of bloodborne infections. SSPs have been shown to reduce HIV and hepatitis C infections by about 50%, and when combined with medication-assisted therapy, they work even better. So SSPs also prevent overdose deaths, as Admiral Giroir had mentioned, by tripling the chance a person will stop using drugs, as well as by distributing naloxone to the people who will be close by when overdoses occur. SSPs also protect the public and first responders by reducing, though not eliminating, needle litter in the community. There's been a relative sea change in the level of support for SSPs across the country. However, to work well and sustainably, SSPs need to be supported by the local community, law enforcement, and public health. SSPs should strive, if possible, to provide the full range of services. In doing so, they will save lives, help clients get the support needed to regain a healthy life, reduce the impact of drug use on the community, and in doing so, gather support from the community. So to help, 2 months ago, CDC published a suite of materials, including a summary of information on the safety and effectiveness of SSPs in reducing viral hepatitis and HIV, fact sheets outlining the content and effectiveness of SSPs, and frequently asked questions and answers about SSPs. All of these materials are available online at www.cdc.gov/SSP. We also recently released several funding opportunities that will strengthen the capacity and improve the performance of SSPs by supporting technical assistance to ensure the provision of high-quality, comprehensive harm reduction services, implementing a national SSP monitoring and evaluation program, and supporting the development and implementation of best practices for patient navigation from SSPs to healthcare and social services, as well as medication-assisted drug therapy. Increasingly, SSPs are becoming a normal component of an effective public health system. Thank you, and back to Sharon.
Thank you so much, Admiral Merman, for that excellent overview. I like how you said how to win the fight and save lives and money at the same time. Our next presenter is Ms. Heather Houck, Deputy Associate Administrator with the HIV/AIDS Bureau at the Health Resources and Services Administration, and she'll share more about what HRSA brings to the table. Ms. Houck?
Thank you, Sharon. And thank you to Admiral Gerard and Rear Admiral Merman for the important overview of the landscape of the opioid and injection drug use epidemics and their impact on individual patients' health as well as on public health. I'm very pleased to be able to share with you today, have the opportunity to share with you today some examples of HRSA's partnerships with and support for syringe services programs. I hope that many of you are aware that there are a number of HRSA programs that are directly involved in addressing the opioid crisis in the United States. Through our Rural Health Program, our Health Center Program, our Maternal and Child Health Bureau, and our workforce capacity initiatives, especially around behavioral health, are all opportunities for HRSA to increase our impact in terms of addressing the opioid epidemic. Today, on today's webinar, I am going to be talking specifically about two of HRSA's programs. First, the Ryan White HIV/AIDS program, which works with cities, states, and local community-based organizations to provide HIV-related services to over 500,000 people each year. And the HRSA Health Center program, which provides care to more than 27 million patients in the U.S. That's 1 in 12 people in the United States, and they serve 1 in 3 people living in poverty and 1 in 5 people living in rural communities. So as you can tell from those statistics, there's a real overlap with the statistics and the information that's been shared previously on the webinar and the populations that we serve. So in terms of our guidance around the use of HRSA funds for syringe service programs, in 2016, when the Department of Health and Human Services issued the implementation guidance to support certain components of syringe services programs, HRSA also developed and issued a specific guidance on the use of HRSA funds for syringe service programs. I'm not going to read the information outlined on the slide. We did provide the link to the HRSA guidance at the bottom of the slide, and we would strongly encourage people to review the guidance in full. I would note that the second point around submitting documentation via our electronic handbooks, the documentation that's required for submission are actually the CDC notification to the applicable state, local, territorial, or tribal health department that the evidence submitted by the health department is sufficient to demonstrate that the jurisdiction is experiencing or is at risk for a significant increase in hepatitis infections or an HIV outbreak due to injection drug use. And in addition, a certification in the form of a letter signed by the health officer from the state, local, territorial, or tribal health department that such a program is operating in accordance with applicable law. So we want to emphasize the documentation requirements in order to start the process to request the use of HRSA funds for syringe service programs. In addition, it's important to note that for HRSA Health Center programs, they also need to consider their scope of projects. So those health centers that already include substance use services within their scope do not need to go through the prior approval process. But for those that do not have substance abuse services within their scope of project, they do have to submit a scope request to add those services in order to implement or to support a syringe service program. After we issued the guidance in 2016, beginning in 2017, the HRSA Notice of Funding Opportunities clearly identify whether the programs that are funded under that particular NOFO or a contract are permitted to support SSPs, including any criteria for eligibility and any specific budgetary or programmatic requirements. So with that as background in terms of the process of using HRSA funds to support or to partner with syringe service programs, we thought it would be a good opportunity to share with you a few examples, some through the Ryan White HIV/AIDS program, and then some through the Health Center program of how these partnerships or these supports have been implemented with HRSA funding. So on this slide, we have just a few examples of some state health departments that have actually been supporting syringe service programs with Ryan White HIV program funds. So in the first example, in Montana, they actually have been using their state funds, their Part B funds, to pay for staff, HIV and hepatitis C test kits, linkage to treatment and care services, educational materials, and other supports. It is important to note that with each example, the Ryan White funds can only be used for people who are eligible to receive Ryan White HIV/AIDS program services. So each of the states do have to determine eligibility for the individuals that they are serving in the SSP supported programs. In Utah, they've actually been able to use a service category in the Ryan White HIV/AIDS program called the Early Intervention Service category to support targeted HIV testing, outreach, and health education risk reduction, linkage to care, and referral services through the SSPs within their state. And then the last example certainly is Wisconsin, and they actually have been supporting the SSPs in their state to purchase supplies, doing HIV testing, education, and outreach. And again, this is a non-exhaustive list. We have a number of other examples where individual clinics or other local health departments, our Part A's, have also supported or partner with syringe service programs. In terms of the HRSA Health Center programs, again, a non-exhaustive list, we just mentioned a few. There is the Albuquerque Healthcare for the Homeless program and their harm reduction outreach program. They use a state Department of Health approved curriculum, an overdose prevention curriculum, and have, you can see the numbers, they've certainly distributed over 2.5 million syringes and collected 41% of those, including through their center drop box. In addition, they also have been tracking overdose prevention activities and know that they have prevented at least 248 overdoses through their efforts. In addition, they've also been able to increase navigation into hepatitis C testing or treatment. So they've actually navigated almost 400 people with injection drug use into hepatitis C testing or treatment. The second example is actually Circle Health Services in Cleveland, Ohio. They operate one of the only syringe exchange programs in Ohio and really focus on reducing the incidence of HIV and hepatitis C by providing supplies as well as needle exchange. The First Nations in Albuquerque, New Mexico also focuses on overdose prevention education, sterile needle exchange, and naloxone distribution. They have a very flexible system that allows for both walk-ins and appointments. And they really focus this program as an entry point into hepatitis C and HIV testing and treatment and linkages to the various services that the individuals who are walking into the program need, whether that's behavioral health or other healthcare needs. And then last but not least, Outside Ins in Portland, Oregon, their injection drug user health services also focuses on a harm reduction model. They serve nearly 5,000 people who exchanged over 1 million syringes in a 1-year period. They also provide overdose prevention trainings and distribute naloxone. And in the last 5 years, they indicate that they've had over 2,000 overdose reversal reports through their reporting system. So we greatly value the work that's being done in the Ryan White program and the Health Center program, as well as across other HRSA programs. We are constantly learning of additional examples of where the relationship or the partnerships of the support between HRSA programs and syringe services programs are occurring, and we strongly encourage and promote peer-to-peer technical assistance to continue the growth of those partnerships between HRSA-funded programs and syringe services programs. And with that, I'll turn it back over to Sharon. Thank you.
Thank you so much, Ms. Houck, for that excellent overview of the opportunity to leverage HRSA funds for SSPs. Our next presenter is Dr. Jim Gandotra. He's the Chief Medical Officer at the Substance Abuse and Mental Health Services Administration, and he will share more about the resources and assistance available from SAMHSA.
Good afternoon. Thank you for the introduction. I'll be filling in for Dr. Eleanor McCants-Katz, and I'll be briefly talking about the intersection between HIV and substance use disorders, harm reduction strategies. I'll review some of those that have been previously mentioned. And the most important thing is that it'll be a call of collaboration. So, as background, we know many programs specializing in treatment of mental health and substance use disorders don't always have the necessary experience in the provision of other types of health care. And despite, the serious infectious diseases that HIV and viral hepatitis represent, some of these programs have limited staff or resources to address the HIV risk in their patients. I'm going to just briefly highlight the data that's listed here, and this is from the National Survey of Drug Use and Health, and it should exemplify the burden that those with HIV are carrying when it comes to both substance use and mental health. For instance, the data shows 7.4% of U.S. population 12 and older has a substance use disorder, compared to almost 3 times that for those with HIV. Illicit drug use disorders represent 2.8% of the general population, compared to almost 15% with regard to those with HIV and AIDS. For mental disorders, the trend is also concerning. While 18% of the general population have any mental illness, comparing that to almost 38% of those with HIV demonstrates how much of a burden they're really carrying. And in particular, it looks like the numbers are clearly double for most individuals. So this is an important issue that we need to address. So why is it really important? I'd like to highlight how important the intersection of these two disorders really is. When one gets worse, generally compliance treatment for the other gets considerably worse. These are interactive and congruent disorders. So when there's IV drug use, certainly the person who is at risk for HIV infection, they may be using contaminated or used needles to inject heroin. And of course, when we can get patients into treatment, a lot of these high-risk behaviors diminish. In fact, the idea that once a person enters treatment, they engage in other treatment-seeking behaviors. that will reduce their high-risk behaviors. Of course, as previously mentioned, medication-assisted treatment is going to be the first option that we would like to put forward for patients who have opioid use disorder. It's been shown that when coupled with syringe service programs, it will reduce harm. Education, decreasing IV drug use, those are our short-term goals. The longer-term goal will obviously be to decrease the spread of the infection. So, as I mentioned, a call of collaboration. You know, the local communities and local agencies probably know best what they need, but our goals are shared. We want to reduce the risk of HIV, reduce new HIV and viral hepatitis infections by increasing testing and diagnosis. We know that the more that individuals, when they know their status, it reduces risk. It reduces the high-risk behaviors as well. We're addressing it through our substance abuse prevention and treatment block grant funding. A lot of things have already been mentioned. Generally, just to run through, preventive interventions and community recovery supports are definitely evidence-based. Providing direct treatment is, of course, our next option, as well as informing all the providers of the importance. This cannot be understated, that education for the providers is equally important as education to the patients. Utilizing the technology transfer centers. Their purpose is to develop and strengthen specialized behavioral health care and primary health care workforce to provide that prevention, treatment, and recovery support services for both substance use disorder and mental illness. But in this case, to address the HIV and viral hepatitis interface. And they can provide direct training in their local regions. And then, of course, working with parent agencies to eradicate HIV. So some of these have already been mentioned, but the most important issue is that harm reduction does work. IV drug use risk reduction should be best approached in stepwise fashion. For instance, abstinence from illicit drug use is obviously the best way, but then utilizing clean instrumentation would be another way of demonstrating harm reduction. Communication utilizing social media technologies and outreach designed to raise awareness. We can hire staff, have the local programs hire staff to support these syringe support programs, and as well as testing for HIV, for hepatitis, as well as syringe disposal services. These are all ways to decrease harm, as well as when it comes to sexual activity, male and female condoms should be made available. We want to increase the provision of linkage of HIV care as well. You can certainly provide direct therapy, antiretroviral therapy as well. So there are lots of allowable uses, and the local communities can certainly be creative when it comes to this issue. HIV testing, we've demonstrated in several studies that the more people know about their status, the less likely they are to engage in high-risk behaviors. Certainly the treatment and care services, pre- and post-exposure prophylaxis, prevention of mother-to-child transmission and partner services, direct substance abuse disorder treatment, and mental health care. Case management services definitely are worth a separate moment to think about, in particular when it comes to navigating between all the specific services and the public and private funding options. Having a guide to help you through this. Most importantly, having the education about what may be the best fit for that person. Case management services provide a vital role there. education, again, not just for the patients, but also for the staff, so that they can be knowledgeable in trying to give the patient the right information at the right time. Safer injection practices, how to actually use naloxone, HIV prevention, testing, treatment, care services, mental health services. They all are fair game to be used as funding. So our role, we want to provide treatment for mental health services for those living with HIV. We want to make sure that the prevention services for those at risk is properly disseminated at the most vulnerable locations and, most importantly, at the most vulnerable populations. Those with substance use disorder and mental illness, of course, when they're not doing well, they're at higher risk. And then certainly all identified infections or those at high risk need to get the prophylaxis and appropriate referrals. I want to highlight again the need to utilize the technical transfer centers, technology transfer centers. They will provide direct training and assistance if you reach out to them. And then, of course, globally to provide training and technical assistance. Most importantly, the President's emergency plan for AIDS relief, those countries to assist in building treatment programs for mental substance abuse disorders. We'll definitely need collaboration all the way through.
Thank you, Dr. Gandotra, for that excellent overview, especially of the intersection of substance use disorder and mental illness and HIV, and also SAMHSA's role in ending the HIV epidemic. And thank you to all of our presenters for presenting as you did. And now we get an opportunity to hear from our participants. And I trust that you all have been typing your questions into the Q&A pod throughout the presentations. And we're excited to read as many as we can. But please note that if your question is not read aloud today, your voice still matters. And regional health administrators across the country have committed to reviewing all of the questions received and analyzing the themes and the types of issues that arise from various sectors and regions of the country. And this will help to inform our approach in this effort and also the content of future webinars. So now I'm going to turn the microphone over to Karina Dan in our Office of Infectious Disease and HIV/AIDS Policy, and she's going to facilitate the Q&A session. Karina?
Thank you so much, Sharon, and thanks again to all of our speakers. This has been a really terrific webinar, and I think we've covered a lot of ground here today, but we see you still have some questions. So we're going to work our way down the line. Hopefully we'll get to most of the questions that have been asked thus far. We have a question from Anna Nelson. Availability of drugs is a big problem, but the demand for these drugs is the real problem. What are we doing to understand the roots of the drug abuse phenomenon in our society?
This is Brett Giroir, and thank you for that question, Anna. Of course, this is something we work on and struggle with on a daily basis. And let me just say it's sort of a few different levels of upstream intervention. At sort of a downstream upstream intervention is to decrease, for example, the inappropriate prescribing of opioids, which we know fueled the first round of the opioid epidemic, led to heroin and fentanyl. And even now, many methamphetamine users really are polysubstance users that started their substance use with opioids. So that's sort of one level of reducing the demand. Secondly, I think you heard that many individuals with substance use disorders also have coexisting mental illnesses. And across the government, we're really working on supporting that, whether it's SAMHSA with all the great work they do, or programs like the HRSA community health centers that have the availability of not only physical medicine, but mental health services and substance use within their same facilities. So it allows the coordination of care. And then very further upstream, we're really always working, and we have new emphases on the social determinants of health. And this really fits into the Secretary's initiative on value-based transformation, we don't want to wait till people get sick and then treat them. We really want to work as upstream as possible. And that deals with housing, food security, transportation, all the types of things that could lead people down a bad road of health. We certainly support and provide lots of technical assistance on trauma-informed care. Many people who use methamphetamine, depending on where you are in the regions, but have had tremendous adverse childhood experiences, and really their care needs to be looked at through that level. So you are exactly right. We don't want to just treat the symptom. We want to treat the underlying condition, and we really work on that at every level we can.
Thank you, Admiral Giroir. The next question we have from Jessica Hessler. As an advocate in Pennsylvania, a state where SSPs are illegal, how can you all help us educate key decision makers? Dr. Merman, can you help answer that question?
Sure. Well, I think all of the agencies, including the Office of the Assistant Secretary of Health, are interested in sharing information with people who are making decisions and implementing programs. So we do have frequent requests for either information to be provided in forms of articles or fact sheets or kind of standard written information or slides that can be useful for people on the ground. But we also actually travel to different jurisdictions sometimes to actually provide information to either community meetings or to other smaller engagements with people who either activists or health departments or parts of the government want really to ask the questions out in a form that is the most useful for them. And I know that obviously the regional health officer staff out of the ASH's office are also able to provide information and sometimes have contacts at that local or regional level that can be quite useful as well.
Great. Thank you very much, Dr. Merman. We have a question from Chuck Isenhart. Looking forward to hearing about best practices to include users in peer outreach. The good news is that we are planning 2 additional webinars in the coming months, and I hope that all of you will stay tuned to the ASH's channel. You know, he'll be helping to promote those webinars once the dates and speakers are finalized. So please do stay tuned. We'll have best practices in future webinars. We also had a number of questions about how to find out where your regional health administrator is. The website where regional health administrators are listed is now in the notes box. You can go to hhs.gov/ASH, that's ASH, and look to the regional health administrators there. I'll move on to Bobby Bagley, who asks, funding appears to be restricted to purchase syringes, restricted for purchasing syringes. What about purchasing sharps containers and covering the cost of disposal services, in addition to paying for staff that do outreach and dispense syringes? Would any of the speakers like to answer that question?
Yes, I can answer that. This is Jim Gandotra. Certainly, disposal services are covered, as well as anything except the actual syringe, I think, is fair game that you could utilize it, because what we're really just talking about is the decreasing the spread of the infectious disease problem.
And Corinna, this is Heather, if I could add to that.
Sure. Thanks, Heather. Go ahead.
So first of all, hi, Bobby. Hope you're doing well. Good to see you on the webinar. So in the HHS guidance and certainly in the HRSA guidance, there's a list of examples of the use of funds that can be used. So it does include personnel, supplies, testing kits, navigation services, educational materials. There's a whole range. So we would refer you to the guidance so that you get the comprehensive list of allowable cost and the use of funds for syringe service programs.
Thank you so much, Heather. We have another question. If you could, one of the speakers could clarify what drug preparation equipment is, what might constitute that. Perhaps Dr. Merman, could you answer that question?
It would include cookers and other materials that are involved in direct processing of drugs for injection.
Thank you, Dr. Merman. We are working down the list of questions. This is a great interactive crowd. Unfortunately, sometimes when you enter in a very long question, it's very difficult to read the end of it. Actually, it's impossible given the format. So I apologize for some of the longer questions. But now we have a question from Steve Holman. What role will SSPs play in the new Ending the HIV Epidemic plan?
Thank you, Steve. This is Brett Giroir, and obviously we approach these two initiatives as intersecting and interconnected. So SSPs will play a critical role in the Ending HIV initiative. And I would just say we have a number of individual plans that are ongoing now within HHS. And although they're individual plans because we respect the need to have them, they're really all interconnected, such as the National Viral Hepatitis Strategy, the Ending or the National HIV and AIDS Strategy, the Sexually Transmitted Infection Strategy, because these are really all interlinked. And as we said, they are really syndemics. Sexually transmitted infections can greatly increase your risk for acquisition of HIV. So yes, we're all going to be talking about that. If you're going to an Ending HIV initiative, we'll talk about SSPs. If we are in an Ending opioids or methamphetamine, we will also be talking about SSPs.
Thank you, Admiral Giroir. I saw a great question just a moment ago. This one may be best answered by Dr. Merman as well. If a state has previously received a waiver to use HIV funds to support SSPs, does that waiver need to be resubmitted? If so, how frequently?
So when we carefully examined the legislation regarding the use of federal funds for SSPs, and it did not require that we recertify health departments. And because of that, we chose not to put in a date for recertification. We felt that the time course for change is in a matter of years. And so if it turns out that a health department feels that they have completely taken care of the problem, I suppose they don't have to continue having syringe service programs anymore. But at this point, the determination of need has no expiration date.
Terrific. Thank you, Dr. Merman. I think that we are running out of time. We are 2 minutes before the hour, and I know we have just a couple of conclusion and reminders, so I would like to turn the webinar back over to Sharon Ricks.
Thank you, Corinna. We have truly enjoyed that question and answer session and really been informed and engaged and inspired. And I hope you leave this call knowing that HHS is committed to combating the nation's opioid crisis by expanding access to SSPs. And we believe this is an important community-based intervention that reduces the transmission of HIV and hepatitis C, helps people access substance use disorder treatment services, and ultimately saves lives. So thank you to our planning committee, our presenters, and our participants for your active participation. Thank you for listening, thank you for sharing, and have a good rest of your day.